I'm here to talk about the unconnected. And I have to say, when Felix called me again, I thought about it. I don't have that much first-hand experience with pulmonary atresia, maybe 2 or 3 publications, that's about it, and I'm sure nobody's aware of that. But I guess why Felix called me, I think he called me because, when you're constrained with limited resources, you're likely to leave the most complex patients alone. And that's going to give you insights that's worth sharing with all of you. I think that's a very sound premise, but I don't know if I'll live up to that expectation. I'll try. So by way of introduction, I think this is where I come from, southern India, Kerala. It's different from the rest of the country. It's not representative. Infant mortality is much lower. Many more pediatric heart centers. For the 30 million population, we have now 5 centers that do infant heart surgery. Different from when I started off, it was the only center practically doing infant work. So in 15 years, we've really grown into trying to reach out to the average child, but we don't probably still reach out to a substantial number of patients. Resources are a massive constraint even now, and single corrective surgery, transposition. The average child, about half of them, you can expect the half children born with transposition will get surgery in a timely fashion. So single surgery is a big deal. So multiple surgery is a huge deal. It's really challenging to expect. And there's a saying in India, marriage and cardiac surgery tends to happen only once in their lifetime. Both are changing actually now. So if you look at the rest of the world, we're sort of representative of the world, where we are. In some ways, if you look at it, and this is regions classified by human development indices, and where we are in southern India, that's sort of like the light blue parts of the world where you have infant mortality hovering around between 10 to 15, 10 to 20. And so you do have the need for pediatric heart care, but you're certainly not in a situation that you are in Europe where you're looking at the really difficult end of the spectrum and how to fix that. That's your dominant question. In India, the dominant question is how to reach out to the average child. And that's the situation most of the world at. If you look at the world population cartogram that expands areas based on population, you find that the overwhelming majority of the world's children live in these areas. So when we talk about the average child in this world, it's a different story. And I'm going to present that perspective to some extent. So, you're familiar with this. I've greatly simplified the classification for the purpose, initially at least, and we're talking about this by and large, but there is clearly a continuum, and you don't have to make these very strict criteria sort of divisions, but we're looking at essentially the most difficult patients and how do you deal with that under these circumstances. It's most challenging from all perspectives. From the patient's perspective, from the family's perspective, particularly in populations where there's no general health insurance, but even notwithstanding health insurance, it's a huge challenge. And it's a challenge because of uncertainty. For a given patient, the road ahead is completely uncertain, and nobody has good answers. Neither does the cardiologist has good answers, the surgeons, nobody knows exactly what's going to happen, and the roadmap is very, very uncertain. It's challenging from the surgeon's perspective, and you heard that. Not everybody likes to venture into this really difficult. There are not many Frank Hanleys in this world. Cardiologist's perspective, of course, you had some extraordinary, the presentation that by Mark was telling you what a cardiologist can accomplish in this particular situation. But it's really high-end stuff. There are not many cardiologists who can do the kind of work that was being shown, and there are not many centers that can support that. And even from an imaging perspective, it's not so easy. But it's really the worst challenge from a health system's perspective. If you look at a situation where your resources are finite, you have a certain amount of money allocated for congenital heart surgery, would you then support somebody who needs 5 or 6 high-end procedures, or would you try and then use those resources to help 5 children who need corrective surgery? So it's an ethical challenge from a health system's perspective. So the decision to do something in these rather challenging circumstances, and I think in any circumstance really is a balance between what you can predict with the natural history versus what you can do in terms of predicting the long-term results of whatever strategy you're trying to embark on. And it's the balance that decides what you decide for a given patient. You know it's not an easy situation to address. There are uncertainties at every level. So let's look at natural history. I'm going to start off with a patient. And I've taken his permission to show you his picture. I told him I'm going to Germany to talk about your condition, and would you mind sharing this picture? He said, sure. But he asked me, would you come back with answers that can help me? And I said, I'm not so sure. I said, anyways, this is Joel Anthony, my very dear friend. He's 28. He sees me every year with his father. His father is growing older and getting increasingly worried about what's going to happen to Joel. I cathed him 15 years ago. And he had disconnected PAs. And as we would in India, we would leave these patients alone. And we left him alone. And every year he comes back to me. He's blue. He's 85%. He's an IT worker. He's able to carry out his work. He goes to his place of work, and he does a reasonable job. And he's limited, but he's not altogether distressed. But there's a lot of worry in the family. That's the story. And I have many Joels in my practice who keep coming every year. The point that I want to make here is that when you see somebody like this, and I think all of us have this problem, we get conditioned. We get conditioned by patients whom we see heavily. What we don't see is this. We don't see what happens to patients when they die. As a result, we tend to have a rather skewed outlook towards this problem. We don't understand natural history. We don't internalize natural history. It's not something that's intuitive. It's something that you need to actually deeply think about. And this is something that this is a book I would recommend to all of you. It's a book that just lists out all these cognition blind spots that we have in our lives. And one of the first things that he talks about in this book is survivorship bias. And it's really this which seems to have a big influence in the way we think about our patients. And I think there's a need to think differently. When you talk about natural history of disconnected PAs, you're talking about the natural history of collaterals, about the lung segments that the collaterals supply, about the heart, and the effects of long-standing hypoxia on the heart, which is not trivial, by the way, other organs, and the patient as a whole. So if you look at, of course, this was so elegantly illustrated and presented yesterday, but essentially we are looking at a situation where a number of connections exists in utero, which somehow get retained, and a whole list of possibilities emerge out of a developmental malfunction, which is shown by these 7 examples, but in reality there are infinite examples. Every patient is unique and different in whatever combination and permutation of collateral versus native pulmonary arteries that develop or don't develop. Collaterals, a lovely study by Sheila Haworth Glennis has actually done a necropsy study, and she looked at collaterals of various kinds, and all the points that were illustrated in Mark's presentation has a basis from this particular study. If you look at it, intrapulmonary arteries are shown here. They could be supplied by collaterals, which could be elastic all the way through, or substantially, or elastic initially followed by muscular collaterals, or if you look at it, they could be muscular throughout. And these elastic collaterals can start off from the aorta with a very big lumen, go on to become muscular with a varying degree of intimal proliferation, and then finally look exactly like the intrapulmonary arteries. Those that are stenotic at origin, and again Mark alluded to this pretty nicely, you can have an extremely thick layer of media that is really unyielding in terms of ballooning, not because of anything else, but it's very thick and it's extremely resilient. So these are the areas that Mark presumably opens up with cutting balloons, and then they yield to some extent. Unobstructed collaterals, you see, in fact, this particular collateral was in the same patient that I showed you, that the previous slide has another set of collaterals that are obstructed. So you have a big variety within every patient. Unobstructed collaterals tend to be more or less elastic at origin. And then if you take sections at various levels, you have what looks like aorta initially, and then what looks like a muscular artery. And then you have these intimal cushions as the vessel approaches the lungs, which can presumably protect to some extent. And then you have the intraparenchymal vessels that are actually quite small. They're small to start with, and they continue to remain small for the rest of their lives when compared to normal vessels that are seen through a normal pulmonary vascular-tree. What about acquired collaterals? And I think for sure there is pretty good evidence of angiogenesis that happens in human body within the lung vessels, and we see that very good examples of that we see when we look at our own patients that grow really old with chronic hypoxia. And we know that they form, perhaps they reach the lungs along the bronchial trees. They can become substantially big, but they remain extremely tortuous. They do perhaps contribute to patient well-being, because we've had several patients who start off with terrible looking pulmonary arteries at the beginning. You don't think they'll make it, and then you see them 12 years later, they're still alive. How did they still survive this period? It's presumably because additional collaterals form and they somehow keep them going. What can you do with them? Very little, but they can be good and bad. They can be a pretty big nuisance for redo surgeries, and they can cause extremely difficult to manage hemoptysis. So these are some examples. This is a 22-year-old gentleman with a single ventricle physiology who has central PAs, but I catheterized him recently because in a preparation to get him down to a corrective surgery. Actually, he has a borderline single ventricle, two ventricle situation. They're getting him to have a difficult two ventricle repair, and the surgeon wanted me to get rid of as many collaterals as possible. And you can see this is an extremely daunting task. There's so many of them. And you can realize that a lot of the native vessels have been recruited in the process. They can come from the internal mammary, the bronchial, the vasa vasorum of the aorta, the coronaries. Anything can get into the act of contributing to the pulmonary blood flow. Unpredicted collaterals, and this is a very striking example that's been provided by my MRI colleague, Dr. Mahesh. And this is a patient who has a very large unprotected collateral and one well-protected collaterals. The well-protected collateral, this is from behind. So this is to the right lung. You can see the density of the vasculature. This looks almost like a normal lung. And then the unprotected one, which is clearly Eisenmengerized. And both within the same patient, who's now 18 years of age. You do an MRI, derived flow, and you can realize that the right lung gets much less pulmonary blood flow than the left lung. So this is sort of a natural history experiment that we have seen. But fate of the collaterals are somewhat linked to the fate of the patients, but not in a way that you can actually predict. The consequences of hypoxia are significant. Even mild hypoxia over a period of time can have disastrous consequences eventually, both acute and chronic. Brain abscess is something that we see a lot more commonly in India and in the tropics than you perhaps see them here. Strokes, especially when you have relative anemia, and doing repeated venesection is one way of making sure your patient will get a stroke. Hemoptysis, big problem. Ventricular dysfunction, long-standing hypoxia, we see very commonly developing ventricular dysfunction. And of course, there are a host of neurodevelopmental consequences. This is an example of a brain abscess, but this is more striking, a watershed infarct, a massive watershed infarct in the context of relative anemia in a patient with severe hypoxia because of the altered rheology of blood cells. So how long do they survive? They survive without treatment. There is data from the 70s down till the 90s, but they all show very similar patterns of survival. That's about a 50% attrition before the age of 1 year, median death at around 1 year of age, and then progressive attrition thereafter. And the ones with complex pulmonary arteries, atresia, tend to do the worst. But it's not clear what actually determines survival. And the very limited data that's available from this very nice prospective natural history study from the UK, it was not possible to actually identify what variables are associated with survival or the lack of chance to survive. It's not the number or size of MAPCAs, the central PAs, perhaps because of the kind of very small numbers that existed within this study. It's difficult to actually identify what translates into survival. This is another study, more recent, but very often quoted study from Kate Bull that shows the similar sort of survival pattern in patients with complex pulmonary atresia, not all of whom were left alone, but a substantial majority was left alone in this situation. So can we improve upon this? And what you have to undertake to improve upon this is quite significant. So the available information, there is a lot of problems in interpreting that data. The issues are, one, the studies, it's a rare disease, so studies have relatively small numbers. Diverse patients, not every patient is the same. There's tremendous diversity. There's variable expertise, and I think that's something that you will all recognize. There are different approaches. The 3 different surgeons, 3 different surgical approaches, each very passionate about their approach and saying that that's the right approach. So we don't know. And then there is a tremendous publication bias. I'm pretty certain nobody is going to share their results if it is really lousy. So that's another problem. And then there is a selection bias. For the patients who get referred to surgery, it's quite likely that that is not representative of what's out there in the community. So there might be filters at various levels. We as cardiologists will say, oh, this looks really bad, we'll not send it to surgery. So that's a lot of biases that come in. And then the duration of follow-up, I think it's really short. Within a lifetime, within our lifetimes, we can't actually write a paper that has adequate follow-up, maybe 5 years, 10 years. But we can't actually get the 20-year follow-up that you really need to talk about these patients. So there is a real problem with interpreting surgical series and trying to compare it with natural history. We'll try anyways. What about palliation? I think Mark, I don't need to emphasize, the previous presentation had some fantastic data on trying to balloon dilate and stent collaterals. Yes, they are unpredictable. Some do not yield. You can balloon them with cutting balloons for sure. There's an early improvement in saturation. I don't know how long that is sustained. Does that translate into growth of collaterals? Can those collaterals be rehabilitated and unifocalized subsequently? Not so sure. There's a prospect of spasm and aneurysm formation. We're all aware of this. And this is actually Mark's group that published this quite some time ago. I know a lot of it has changed ever since. This is the picture from his publication that showed a 20 atmosphere pressure not being able to open up the balloons, but another collateral opening up with much more impressive results with this same balloon. So in our own data, we've embarked upon stenting the PDAs in older patients in whom it's possible to stent the PDAs. Disconnected PAs, but PDAs supplying one pulmonary artery. So we've then undertaken that, and we found that you can actually get some good for some time, but it doesn't sustain itself. So over a relatively short period of time, the saturations start to decline. What about correction? I wouldn't go into it because it's been sort of heavily discussed, but I just, maybe this is one easy area to fix, because you can put a stent into each of these bilateral ducts, and then you can bring them to follow it up, make sure the PAs have grown, and then you bring them together, as we recently did in one of our patients that I'm showing you here. But when you have complex pulmonary atresias, and this is Frank Hanley's strategy that is most recently that I could find in one of his publications, there is, of course, some subjectivity here. He talks about hypoplastic PAs, but doesn't exactly describe what is hypoplastic. He talks about collaterals with stenosis and without stenosis, and then he describes this as an example of collateral without stenosis, and describes this as an example of collaterals with segmental level stenosis, and then says that you could actually rehabilitate all of this with a single stage unifocalization, and this would require more of a staged approach. Then, of course, these are these lovely, pretty pictures, and you always show the best pictures in your publications. And this is an example from Mohan Reddy's publication where you can see that everything has been unifocalized. Of course, there are areas of stenosis, which he says can be ballooned, not mentioning whether all of them yield or not, and that's the uncertainty that we have to deal with. The results overall of Frank Hanley's strategy is incredibly impressive, but just very hard to reproduce, I think. There are very few others that have shown the same level of results where you can actually do a single stage unifocalization in 76% with very good survival and even more impressive RV-LV pressure ratio, and a statement being made that they are the same for those without PAs versus those with PAs. So the actuarial survival is very good, but the freedom from intervention is really terrible. Completely different views from Christian Brizard and Roger Mee's group, who just don't believe that collaterals can grow and become a part of the whole strategy, and they cannot be unifocalized, and essentially very divergent results being shown by this. Our own experience, just as I boarded the flight on the same day, I had to catheterize a baby who was not coming off the vent after a unifocalization, and the surgeon felt that he had done a pretty good job, but you can see that the unifocalized vessels to the lower lobes in the right side and left side were pretty stenotic. There were attempts to improve, open them up, lay them open, but it hadn't really worked. So there are different levels of expertise, and it's not clear whether the same level that's been shown in Frank Hanley's study can be extrapolated to a whole lot of the situations that we see in the real world. The unanswered questions are, do collaterals grow? What's the ideal age of surgery? What happens to suture lines in unifocalized vessels? What are the ones that yield to balloon? What are the ones that don't yield to balloon? What are the long-term results of ballooning and stenting? Can you rehabilitate these vessels? And what are the 15 to 20-year outcomes? So the decision is very complicated. But here's what I have to tell you. I think this is my most important slide as I come towards the end of my presentation. We need to think about the average patient in this planet with complex pulmonary atresia. I'll talk about a child that's born in India, and one of these three conditions present. Firstly, a timely diagnosis has to be made. That's a big deal. Only 10%, 20% are likely to have a timely diagnosis, almost like a lottery. Then, needs to be referred to a center, and they have to reach the center, overcoming the geographic and economic barriers. Then an accurate diagnosis has to happen. Accurate meaning you actually map every lung segment. And then you got to find somebody who's willing to take care of this patient, do the repair like the way Frank Hanley or others do. The expertise needs to be present. The costs need to be affordable in a society where nobody's insured or very few are insured. And then conduit needs to be available. It's a huge problem. In fact, the word we have for conduit is can't do it. That's a real problem. And then they have to be subjected to repeated CATs. They have to be willing to do that. There has to be the costs that is affordable, willingness, and more importantly, the expertise to do. These are not easy CATs to do. Another problem, we don't have stents easily available. And then you got to be willing for conduit changes as they grow up. So the barriers are huge. And then superimposed on this is the physical, emotional, psychological, neurocognitive challenges of growing up with complex CHD, particularly if you have catch-22. So take this all together in the real world. It's far more complex. And you add that to the uncertainties that exist within the disease itself and the diversity, it becomes very, very hard. So the default option often ends up leaving it alone. We need to focus, change our focus. Most of the literature today is, yes, we can. We need to change that to, how can we help the average patient? We need pragmatic solutions that are tailored to the lesions, but more importantly to the health and systems that are prevalent in various settings in the real world. And again, three options: correct, palliate, or leave alone. So to conclude, long sentences, but I think there is a massive disconnect between what cutting-edge science can offer and what's actually available to the average child, and PA, complex pulmonary atresia, is a fantastic example. There isn't a better example. So as we progress, within quotes, we need to consciously seek to improve the fate of the families who are really unconnected with our collective expertise. And that's the problem. And finally, not attempting to correct may be still the most pragmatic and perhaps the most humane thing to do. You can devastate a family by offering multiple surgeries to the point that they can be impoverished. And you can do far more damage to the family than in trying to fix what's really difficult to fix. Thank you.